Okay. Hello, everybody. First of all, I want to thank the organizing committee for the kind invitation. So we had a very interesting session about the durability of the valves. So it's very important to assess correctly the severity of the aortic stenosis. So our topic today is about echocardiographic assessment on TAVI procedures. There are no conflict of interest. So when we perform an echo, the first thing we look at is the aortic valve morphology. We try to identify the number of the cusps, which is very important for the intervention, the presence and the degree of possible aortic regurgitation, the size, location, the amount, the extent of calcification, the annular size and shape, especially using 3D software, and possible subaortic membrane or anatomic structures like a sigmoid structure. And reminding the crown-shaped aortic valve anatomy, we try to measure the virtual ring, which is formed by the basal attachment of the aortic leaflets, and its correlation with the mitral valve. It's anterior to the mitral valve, and in between is the aortomitral curtain, and also the conduction system that it's in the membranous septum in the non-coronary sinus, important in case of the interventions. Common errors in their measurements when we use a 2D imaging and try to measure the annulus of the mitral of the aortic valve. This is on the left image. You can see the reason why we have most of the times underestimation of the area of the valve because we don't exactly measure the correct diameter. If we use 3D software, we have better accurate measurements, so it's good to measure that. See, here are some types of bicuspid valves that we may encounter and may have importance for the procedure, for the TAVI. And here are some examples, as you can see, bicuspid and tricuspid aortic valves. So we do a 3D zoomed image of the aortic valve. First of all, we want to measure the area, to do planimetry. We take two orthogonal planes, align them, and measure the cross-sectional area. And we can get good results with that, pretty accurate. Of course, there are automated software that can do that for us. The technology always helps us. And continuing with the aortic valve morphology, we measure the diameter of the sinus of Valsalva, the ST junction diameter, and the distance from the ostia. This is mainly done with CT, of course, but we can do that pretty good with 3D echo as well. We cannot report an aortic valve stenosis, the severity. We cannot grade it without measuring the dynamics, the hemodynamics of the valve, the velocities, the mean gradients, the effective orifice area by the continuity equation, the DVI, the dimensional velocity index, which is independent of flow, and of course the stroke volume, the transaortic flow. Of course, we look at the mitral valve. Is there any mitral regurgitation? What's the severity? What's the mechanism? Is there any mitral stenosis? Is there any calcification of the anterior leaflet? We look at the left ventricle, the size, the function. Are there any wall motion abnormalities? What's the ejection fraction? Any thrombus? Again, the stroke volume of the cardiac output. And we look at the right heart as well. As said, and I'll show in a slide later on, is correlated with the stage and the grading of the cardiac damage, the size and the function of the right ventricle, if there is any pulmonary hypertension, if there's any pericardial effusion. And summarized here on the right-hand side, if you can see on the slide, the imaging evaluation using the echo, as we said. Now, the straightforward scenario, the majority of the cases, we have velocities more than 4, mean gradients more than 40, and the area less than 1. That's the straightforward. We know it's severe aortic stenosis. But there are some cases where there are low flow, low gradient AS with less than 1 centimeter, less than 40 gradients, less than 40 velocities, with a stroke volume index less than 35. And normally concerns patients with ejection fraction less than 50, less than 40%. What do we do then? Then we normally perform a low-dose debutamine stress echo in order to increase the stroke volume, and then we calculate the projected area, so what the area of the valve would be if the flow was normal. So we need to assess the transaortic flow, and if it's less than 1, then it's a truly severe aortic stenosis. If we are not able, for whatever reason, to increase the stroke volume with a stress echo, we perform a CT and we measure the calcium score. And here's an example with low velocities at rest. You can see heart rate 62 and then heart rate 77. So just a small increase in heart rate is a safe procedure. It's a severe stenosis. Another category is the paradoxical low flow aortic stenosis, similar to the previous one, but it involves ventricles with preserved ejection fraction, and it's more frequent in females and in older patients. There are conflicting data regarding the severity of the aortic stenosis, but generally speaking, the outcome is poor. It's important to exclude measurement errors. I'll show you an example of what we mean with that. And if there are inconclusive data, then again, we perform a CT calcium score. So on the left-hand side, we have a 3.9 meters per second with a 5-chamber view, but if we turn the patient on the right, we get a 4.9. So this is not a paradoxical low flow. It was a severe aortic stenosis. We just had to take a better alignment of the velocities. Another scenario is a normal flow low grade in AS, generally concerning patients with an area around 1 centimeter and mid-gradients like 30 to 35. Most of the times it's a non-severe AS, and it actually concerns patients with small body size, arrhythmia, or prolonged ejection time, and generally speaking has better prognosis. And again, this is summarized on this slide. When we have a low flow, low gradient aortic stenosis, look at the ventricle, the ejection fraction, perform a low-dose debutamine echo or a cardiac CT or both. The staging of the aortic, the grading of the aortic stenosis correlated with the cardiac damage. As you can see in stage 4, the right ventricle is damaged and there is pulmonary hypertension. So in terms of complication, if there is any severe aortic regurgitation, any severe mitral regurgitation, any pericardial effusion, any wall motion abnormalities, obstruction of the coronaries, or this, rupture or dissection. And mainly the aortic, what concerns us is the aortic regurgitations, which is not very easy to assess. So we tend to measure the area of the jet circumferentially or take the diastolic flow, reversal flow, as you can see here. So we planimeter with the flex slice, and you can see some examples of mild regurgitation using 3D as well. And this is actually the scheme of grading the severity. I'm zooming on the circumflation area. It's more than 30. With the color Doppler, it's considered to be significant. Continuing with the complication of generally major bleeding, we can see the left ventricle hypercontracting, any thrombus of the catheters, malpositioning of the valve, any fistula perforation, and post-TAVI, of course, we perform an echo before discharge, 1, 6, and 12 months afterwards, unless there is a new murmur or heart failure symptoms. And it's also we have to assess whether any patient mismatch. Also, we look at the valve anatomy and if there's any stenosis or regurgitation after the TAVI, if there's any thrombosis or endocarditis. And this is summarized here on the decision pathway outline on the right side with the heart team decision. Then we're assessing the paravalvular leak, procedural complications, and after TAVI, again, the valve function, the left ventricle, and the systolic pressures. A small vegetation in TAVI, and we can use advanced echocardiographic software with GLS and myocardial index to assess the prognosis as well. And sometimes in valve-in-valve complex interventions, the interventionalist may ask us to, there is suspicion of obstruction of the left main stem, so he may ask us to perform an adenosine stress echo in order to assess the flow and the flow result in the left main and the LAD, which we can do relatively easy. So in conclusion, proper patient and prosthesis selection for procedural surveillance and follow-up are paramount in importance of TAVI success. Echocardiography and multimodality imaging are important in all of the steps. Advanced imaging modalities and technical improvements with automated software, 3D TAVI, 3D transthoracic echo, and GLS have increased procedural success rates. Transthoracic echo remains the mainstay modality for the assessment of prosthetic valve durability and detection of prosthetic valve thrombosis and endocarditis. And I'm closing with Professor Chambers, was a giant in echocardiography at St. Thomas's Hospital. Unfortunately, he passed away a few days ago. Thank you very much.
Thank you very much, Dr. Krommydas. Just one question, and then we can get other questions as well. As we're learning now, DVI, do you also measure it before the TAVI? I've heard some, sometimes there's some echocardiographers that they tend to measure it.
Yes, DVI I consider to be as a very important measurement because it's independent of flow, so it reduces measurement errors, and also it's good to correlate it before the procedure and after the procedure and to see the change. It's a good relation to have in order to have proper assessment of the severity of the aortic stenosis. So I agree, yeah.
Is there any questions or someone else would like to make an input?
So congratulations also from me, Dr. Krommydas, for the nice presentation. One question from me would be, is there any place nowadays for TE or 3D TE periprocedurally? Do we obtain any important information during the procedure that we could not obtain with simpler orthography?
It's a very good question. In the beginning of TAVI, this was an important step of the procedure, but afterwards, because of the planning of the TAVIs, the good imaging for the CT, so they get all the measurements and the data from there, and most of the times they have all they want for the procedure. Of course, there are always some cases that they may ask us urgently to assess a complication during the cath lab, any pericardial effusion, any rupture, but most of the times it's not needed. We as echocardiographers always want to help and get a vision of the valve, but most of the times it's not needed.
The next presenter is